Our monthly cardiovascular disease prevention webinar series at DEBAKEY Studio. Now today, one of the goals of our webinar lives is to have more lively discussions on topics of interest and areas where there is limited information. So today we are moving into a space which is crosstalk about inflammatory conditions and cardiovascular disease. Now, as we have made great strides in reducing the cardiovascular disease overall in the last 2 decades, it's still important to recognize that we are lacking behind in our true understanding of its pathogenesis. As physicians, we rightly pay tremendous focus on risk factors such as hyperlipidemia, smoking, diabetes, hypertension. However, inflammation has been identified as a key driver in the development, progression, and also complications of atherosclerotic cardiovascular disease. Now, over the last 2 decades, led by many luminaries in the field such as Peter Libby, Paul Ritker, and at least now, in 2020, we have clear indication that chronic inflammation in humans is associated with accelerated development of cardiometabolic disease, including MI, stroke, and diabetes. Now, as far as this notion of chronic inflammation is concerned, there is also strong epidemiological evidence that with conditions such as related to rheumatoid arthritis, psoriasis, periodontitis, respectively, and now some new suggestions that not only this risk is with CVD is what I would suggest is that there is a causal or dependent shared risk, but other exposures, genes, inflammatory pathways, it still remain not completely defined where that connection is. Secondly, also in recent years as physicians, we are also seeing a phenomena in rise in cardiovascular disease in the young, and some of the initial insights suggest that younger individuals with inflammatory condition may be particularly vulnerable for early cardiovascular disease risk. Now, for us as preventive cardiologists, I find it particularly troubling and an area that's under-recognized, not only within our primary care communities, but also within our cardiovascular disease colleagues, especially if you look at the guidance from advisory bodies and how to deal with this potentially vulnerable populations. Clearly, these are critical issues. There is less generalized guidance, understanding as best practices. So, today, to disentangle and more importantly, shed light on these key issues, I'm truly honored to have 3 very special guests whose efforts are shaping the direction of cardiovascular health and prevention in chronic inflammation. And more importantly, personally, I'm particularly looking forward to learning from their experiences using at least 2 distinct inflammatory conditions as our case studies, psoriasis and inflammatory bowel disease. First, I'd like to introduce Dr. Nehal Mehta. He leads the NIH Intramural Program of Inflammation and Cardiometabolic Disease. In studio, I have the honor of having Dr. Bincy Fondren, distinguished professor in inflammatory bowel disease, Department of Medicine at Houston Methodist, and my colleague, Dr. Miguel Cainzos, who is the associate director of Preventive Cardiology Research. So in this format today, we'll first have Dr. Mehta share his wisdom and experiences on the cardiovascular disease risk along in this whole idea of chronic inflammation and shedding more lights on his experience with psoriasis, followed by Dr. Abraham giving her insights on the totality of evidence regarding inflammatory bowel disease, and that Dr. Cainzos discussing his perspective from a preventive cardiologist's view. Now, after that session, we will open it for general discussion, and please feel free to send us any direct questions by texting DEBAKEY to 37607 or going online to paulev.com. So now, without further ado, taking any time, I'd like to introduce Dr. Nehal Mehta, and please, Nehal, love to hear your thoughts.
Wonderful. It's a nice seminar to be invited to. I hope everybody can see my screen, and I will get started. Before I do, I just want to just mention that my enthusiasm may be a bit dampened as to current events in Washington, D.C., so I will try to keep it together and make sure that we get through the material. I've been asked to talk about lessons learned from psoriasis. Chronic inflammation has long been associated with atherosclerosis, which is the leading cause of death worldwide. Heart attack will be caused by atherosclerosis and is accelerated by inflammation. And just for the sake of time this evening, I'm going to go through some of these pictures a little bit more quickly and just demonstrate that my lab has been studying the inflammatory cells that are involved in early atherosclerosis, not to the right, not the calcified plaque, but more the non-calcified plaque on the left. And we've really focused on endothelial dysfunction and the early steps of atherogenesis. So as Dr. Nasir mentioned, I do study psoriasis as a human model to understand atherogenesis. Shown on the left is a person with approximately 20% of their body covered in thick plaque psoriasis. And that is associated with immune activation, systemic inflammation, and lipoprotein dysfunction, all of which accelerates myocardial infarction. It's very important to note that patients with psoriasis do have these risks that go on throughout the lifetime of knowing about their disease. This first set of slides is just to get the three other panel members on the same page with the audience that systemic inflammation is highly prevalent in psoriasis. And as cardiologists, if I liken anything to an acute coronary syndrome, it always catches one's eyes and ears. Here I've taken 120 psoriasis patients who have walked into my clinic, compared them to 101 who've walked into my ER with troponin positive EKG change, acute coronary syndrome, and I compare them to non-ACS, basically troponin negative chest pain patients. And what one finds is a 9-fold elevation of TNF alpha and a 5-fold elevation of IL-1 beta in a walkie-talkie psoriasis patient. Second, psoriasis itself, the disease state, modulates lipid composition. So here, imagine you took a light and you shined it through a lipid a chamber of NMR spectroscope. One will be able to see lipid particle number and size. And on the left, you'll see that in controls compared to the right in psoriasis. There is a large component of intermediate dense lipoprotein, which is triglyceride, and also a large amount of small LDL, which is very sticky and causes atherosclerosis, something that we've coined an ApoB shift. So psoriasis itself modulates the lipid composition. Third, when one looks at the ability to remove cholesterol from the body, one thinks of HDL. And here, this macrophage loaded with cholesterol can be visited by a nascent HDL, esterified, and then pooped out into the bile. This process of reverse cholesterol transport is studied by my laboratory, and we've shown that there's a decrement of about 10% of cholesterol efflux capacity in psoriasis. That may not sound like a lot, but if I eat an 80 milligram cholesterol load of an egg, 8 milligrams is going to be retained extra in a psoriatic compared to a non-psoriatic. The epidemiology clearly supports an association between psoriasis and developing cardiovascular disease, as well as death. There are 3 points to this slide. There is 5 years of life lost, and that 5 years of life lost is due to cardiovascular disease, cancer, and infection. Secondly, there's an age interaction where a young psoriasis patient has a 2-fold chance of having an MI. And when one looks at the hazard ratios in fully adjusted models, one finds that there's an increase of 43 to 58% of MI, stroke, dying from cardiovascular disease, and MACE. So seeing this as a public health challenge, my lab has spent the last decade enrolling patients as well as understanding the natural history of these disease. Again, for the sake of time, I'm going to go through this slide quickly. This is a natural history of psoriasis. Starting at a 0 time point visit going out to 4 years, we deeply phenotype each of these patients with a PET CT, PET MRI, coronary CTA. We develop a whole host of blood biomarkers, and then we obtain skin and adipose tissue. We also have a second set of such protocols that study healthy patients, diabetics, and patients with coronary disease, and we follow them for 1 year to understand how the psoriasis progresses compared. Our lab focuses on multimodal imaging, and shown here is a cartoon of the aorta with its great vessels and the coronary arteries. Today, I'm going to focus on mostly coronary CT angiography to understand how vascular health is impaired in psoriasis, but I'm also going to bring up a bit about atherosclerotic or vascular uptake of FDG to determine whether there's an inflammatory component which drives a lot of these processes. So the first picture that I show you here is that this is a skin disease, psoriasis, and the patient on the right has it and the patient on the left doesn't. And what one finds is that in psoriasis, there's diffuse skin uptake, there's joint uptake, there's a heavy amount of liver uptake, and there's this diffuse amount of vascular inflammation, probably due to endothelial cell activation due to the chronic inflammatory response. When one looks at this vascular inflammation and one looks at the amount of psoriasis that the patient has, there is a direct relationship with the amount of psoriasis to amount of vascular inflammation. So shown here is a psoriatic patient with an FDG PET scan, radio-labeled glucose injected, 60-minute uptake, shows a tremendous amount of abnormal uptake in the wall of the aorta consistent with vascular inflammation, comparing that to a control that has an absent amount of vascular inflammation. So this is where I get the funnest part of the last 4 minutes of the talk. What happens if this is truly shared pathways? I'm going to not have time to go through our digital pictures here, but basically the purpose of our lab has been to really understand how coronary arteries can be detecting early vascular disease. And from what I'm able to see, I might be frozen on a slide. Give me 1 second. Please let me know if I've recovered this area of slide. I apologize for this. We're going to fix this in just a moment. And we will reshare. We should be seeing when we start the share again, just in the studio, we should be seeing a picture of a coronary artery cartoon in cross section. And if we are not seeing that, we probably need to refresh. Please let me know on the chat if you are seeing my slides.
Yes.
Now we are. Yeah.
Yeah.
Okay, wonderful. Okay, wonderful. So I apologize.
It's not full screen.
Okay, it should be full screen. Let's go ahead and stop the share. Thank you for that. Just give me a second. I think this must be some degree of Zoom share issue. I apologize. Please bear with me. All right. Okay, here we go. I'm going to try this one more time, and let's hope. I see submit your questions online. I don't see this coronary disease slide. Can we try that from the studio, please?
Make it full screen, the slide.
Yeah, it is on mine. So what we can do is, if you guys can, I will go ahead and stop my share. I will go ahead and send my slides, and I apologize. This is about a 2-minute offshoot because this share screen function, I'm going to try one last time because I just turned off the VPN. Studio, do you see anything?
Not yet.
Okay, fair enough. Just wait. All right, I'm going to go ahead and email off the slides to the studio, and then we can go ahead and get started on that slide. There were five more slides left in the presentation, and so as to not dampen the enthusiasm of the actual presentation, I'm going to just go ahead and finish the slides or finish the talk to stay on time. And I just want to go back to
slides,
full screen.
Just one thought, and then again, how should we view these chronic inflammatory conditions now? So what you definitely show is a lot of association with lipid dysfunction, and of course we're seeing some prothrombotic. So do you think this is more of just an innocent bystander, or they're really partners in crime? Or is there a direct association of CVD, or is it indirectly just because they have dysfunctional lipids or other risk factors?
You know, that's a good question. And I think that the last 4 slides, and I don't think we need to go back, we can just go on with Dr. Abraham and, we can move on with the slideshows. But I would say that what you do bring up is causality, and the ability to prove it would be to say that we can reverse something with an inhibitor that we believe treats the skin disease as well as the vascular disease. These simply are associations right now, but there is causality in the inflammatory pathways because we have 4 good quality randomized trials that have shown that these drugs do reduce systemic inflammation. And then the other piece of this is we have 4 observational studies that show that there's improvement in coronary vascular health following treatment of the primary disorder. So I think that is evidence indirectly to support larger outcome studies, because ultimately, Khurram, what would be needed is an outcome study treating the psoriasis, if you will, right? You're going to be having to treat the psoriasis and then see if their cardiovascular outcomes reduce over time. And I think that that's probably where we're going. And in order to show causality, I think you have to demonstrate this across other disease models.
In journal, if you think that are there any inflammatory markers or the severity of the condition while accounting for all these bystander risk factors, do you think that can at least shed some light on the direct causality here?
Yeah, I think that the best way to go about this, if you look at how we have been able to piece together a story, it started with saying that, look, systemic inflammation is bad across multiple species, preclinical and in vitro models. Moving that out, when you have chronic inflammation in humans, you have an elevated risk of having heart disease and stroke. Finally, when you treat the primary sources of inflammation, the Cainzos study, Colcott, they've shown us that in the right milieu of inflammation, dampening that response can in fact reverse heart disease and events. So I do believe that there's probably something to be done with hand in hand.
But we'll carry on the conversation, and I'm just going to ask Dr. Abraham to give her thoughts on the inflammatory bowel disease, introduce the topic to our viewers, and hopefully we'll have a very interesting discussion in the next 10 to 15 minutes.
Sounds good. So thank you for having me. So it's nice to, as a gastroenterologist, to be able to talk amongst my fellow cardiologists on this interesting inflammatory pathway. So I was asked to give you a little primer on inflammatory bowel disease, so then we can then use that in basic information, then go into the inflammatory cascades thereafter. So there's 2 specific diseases and under the umbrella of inflammatory bowel disease. One is ulcerative colitis, which affects essentially the colon. Now you can have just rectal disease or proctitis, or you can have left-sided disease or the entire colon being affected. Now, when you have inflammation, you can see on the left-hand side that there's areas without inflammation, looks like beautiful colon mucosa. You can see the vasculature very nicely. On the right-hand side, you see severe inflammation where the mucosa is disrupted, there's ulceration, the patients tend to bleed. And inflammation is caused by this inappropriate pro-inflammatory signaling, and there's increased lymphocyte infiltration in the colonic mucosa that contributes to this inflammation. Now, in Crohn's disease, Crohn's can affect anywhere in the GI tract, from the mouth all the way down to the anus. Essentially, though, for most adults that present with Crohn's disease, they have in the right colon to the terminal ileum or the distal small intestine, where it's mostly affected. But in the pediatric population, Crohn's can affect the stomach or even the esophagus, the upper GI tract. Now, again, with Crohn's disease, you see inflammation, and on the left side, you see a picture of severe deep ulcerations during colonoscopy in the right colon compared to a completely normal colon on the left side. Now, in Crohn's, a similar type of inflammation occurs where you have inappropriate pro-inflammatory signaling that takes place, and you have increased lymphocytic infiltration. Now, the incidence of both UC and Crohn's disease is essentially in the early teens to early or late teens to early 20s. So as you can see, these are young patients being diagnosed with this chronic disorder, having to live with it for the rest of their life. So decades down the line with having a chronic disease can lead to multiple comorbidities, and we can talk about inflammation as one of these pathways that lead to potentially cardiovascular disease as well. Now, there are several features of IBDs. Ulcerative colitis and Crohn's can be quite similar, but things that I always let my primary care physicians and other providers to watch out for, which are, we call these warning signals, would be fever, weight loss, signs of malnutrition, abdominal mass on exam, or perianal disease such as fistulas or skin tags would suggest chronic inflammation, such as inflammatory bowel disease, compared to having a functional disorder such as irritable bowel syndrome. In kids, you can actually see growth failure as well. And as far as additional testing, you can see inflammatory markers such as SED rate or CRP being elevated in inflammatory bowel disease, and more specifically, stool markers, fecal calprotectin or lactoferrin, which are neutrophilic proteins, can be elevated. These are sent out in the stool. Of course, if there's family history of IBD, or if you do some initial workup stool studies and they're negative for infection, that would prompt you to refer this patient early on to a gastroenterologist so they can be evaluated. Now, inflammatory bowel disease doesn't just affect the bowel. It affects multiple other organs, as you can see listed here. Joints are affected, eyes, kidneys, skin. Now, cardiovascular-wise, our biggest concern with our patients is an increased risk of thromboembolic phenomenon. Specifically, pulmonary embolism and venous thromboembolism are increased when a patient has an acute flare of their disease. In our hospitalized patients, it's mandatory that we put them on DVT prophylaxis as soon as they step in the door. And of course, a cardiovascular disease, which we'll be talking in more detail about as well. So pathogenesis of inflammatory bowel disease is very interesting. So from a GI perspective, or cells and microbiome perspective, we have 10 times more bacteria in our body than we do have human cells. So essentially, we're just a host for these organisms. Now, what happens in inflammatory bowel disease, there's a dysbiosis that occurs in the microbiome. So you have decreased diversity of bacteria, you have increase of essentially we call bad bacteria, such as certain enterobacteria, and less of the good bacteria, such as Faecalibacterium. And this dysbiosis can contribute to this chronic inflammatory cascade that leads to Crohn's disease or ulcerative colitis. Now, diagnosis, of course, history and physical, as we all learned back in medical school, is very important. However, the standard of care, it would be to do an endoscopy with histopathology. And that can be done with colonoscopies, endoscopy, or capsule endoscopy to look for the small intestine. Now, you can also do imaging to look for small bowel disease where you can't reach by colon or endoscopic evaluation. And other serological testing, genetic testing is useful, but it's not the gold standard. Now, treatments can depend based on the severity of the patient. So you can see here, if you have a patient that has very mild disease, then you start with topical therapies such as aminosalicylates, or topical or GI-specific steroids such as budesonide. However, if they have moderate to severe disease, we talk to them about putting them on biologic therapies or small molecule therapies. Now, there are several different biologics that are approved for inflammatory bowel disease. Three specific categories I want to talk to you about would be one, anti-TNF. So we know that TNF-alpha is a cytokine that's elevated in inflammation in lots of different inflammatory conditions such as psoriasis, rheumatoid arthritis, but also in Crohn's and ulcerative colitis. So we have biologics that specifically block the cytokine to help reduce inflammation. We also have a medication called ustekinumab, which is an interleukin 12 and 23 cytokine receptor antagonist that's earlier in the inflammatory cascade for causing inflammation, and has been approved for treating inflammatory bowel disease as well. Now, we have what we call anti-integrins, that these are leukocyte migrating blockers, essentially. So we don't really use natalizumab because of issues with infection in the brain. Vedolizumab is a very gut-selective agent that prevents memory T cells from getting into the gut. And so we have a very gut-specific treatment for inflammatory bowel disease as well. Now, we also have tofacitinib, which is an oral agent, which is a JAK inhibitor, which blocks multiple cytokines that you see listed here. Now, interestingly, from a cardiology perspective, we see elevations in both LDL and HDL in a similar ratio with tofacitinib. However, we have not seen so far an increased risk of cardiovascular disease with tofacitinib per se in our inflammatory bowel disease or ulcerative colitis population. Now, we do have to personalize treatment. Obviously, we want to see how severe the patient has the disease. So, and based on that, we'll decide on which therapy to start them on. Disease location can play a role, and how extensive the disease is and how active the disease is as well. The other things we take into account, of course, endoscopically, if they have severe disease, we put them on biologic therapy right away compared to some mild aphthous ulcers that we may see. Now, we also take into account comorbidities. We know that patients with inflammatory bowel disease may have other autoimmune type conditions such as rheumatoid arthritis, psoriatic arthritis, and there are different types of medications that are approved for individual diseases. So we kind of try to choose a one-size-fits-all. So if a patient has, for example, psoriasis, we might consider ustekinumab or anti-TNF, which is approved for both psoriasis and IBD compared to a more specific, gut-specific agent. We also have to take into account other risk factors. So, for example, specifically in cardiovascular disease, if a patient has congestive heart failure, we actually avoid anti-TNFs, which interestingly, maybe we can discuss this in our actual discussion, would be that TNF blockade or infliximab, the first anti-TNF, was initially evaluated to treat congestive heart failure. But in fact, when we tried this out, it actually worsened heart failure in these patients. However, we found that it actually worked in inflammatory bowel disease, so we've been using it for that. We have to take caution those that have CHF. We also keep in mind that our goal of therapy in treating inflammatory bowel disease is not just to get our patients to clinical remission where they have lack of symptoms, but we also want to get them to heal their colon to endoscopic remission. But ultimately, our moving from our gold standard to platinum standard, I would like to call it, would be histological healing, where we not only see completely healed colon or small bowel, but under the microscope, histologically, there's no inflammation either. So I'll stop here, and then I'll be looking forward to future discussion questions with everyone.
So, Dr. Abram, thank you so much. We'll move on with Dr. Cainzos, my co-director at the Center for Cardiovascular Prevention and Wellness. And really, he has led effort with some of our colleagues at Houston Methodist in coming up with the review of a very classic review and published recently in JAK, which is really insights providing on why IBD is important, and from a preventive cardiologist perspective, what are the complexities, what's the epidemiology, and how can we at least start thinking about risk management. So welcome, Dr. Cainzos.
Thank you so much, Khurram. Thank you to the speakers, Dr. Mehta and Dr. Abram, especially Dr. Mehta, for joining us today in this complicated situation in Washington, D.C. Can you see my screen, full screen? Can you see my slides? Okay, awesome. Well, thank you so much. And I'm going to be talking about the view of the preventive cardiologists when managing patients with IBD, and also this epidemiology of the association between IBD and ASCVD. So first of all, in terms of the association between chronic inflammation and ASCVD, we actually have strong evidence, as Dr. Mehta mentioned, about the association between chronic inflammation and ASCVD events through atherogenesis and thrombosis. And this comes from three key sources of evidence. We have solid mechanistic evidence, which has been reviewed by Dr. Mehta specifically for patients with psoriasis. And there's this great review by Dr. Libby and colleagues in JAK published in 2018 that goes through each of these mechanisms. For the sake of time, I'm not going to go through them. But definitely the mechanistic evidence seems to be pretty solid. This is also supported by compelling epidemiological data in key populations with chronic inflammatory conditions like psoriasis, HIV infection, and so on. And also we have these key RCTs of anti-inflammatory drugs showing that in patients with established clinically overt ASCVD, so secondary prevention populations, studies like Cainzos, Kolkata, and so on, we see that there's a reduction in ASCVD events with these medications. So this is in general for chronic inflammatory conditions, but what about IBD? So for IBD, this association has not been so clear, and even, for example, for us, when we submitted this paper to JAC, there was some resistance by the editors of JAC because they were not completely convinced about the strength of the evidence. But actually, if we go and check the literature, you can see how actually, specifically cohort studies, which are the strongest type of evidence in the observational research realm, you can see how here, for example, this meta-analysis of 16 cohort studies on the left, and this is studies of IBD regardless of the subtype. On the right is stratified by whether this is Crohn's or ulcerative colitis. And you can see how, first of all, most of the studies, not to say all of them, the point estimate was on the right side of the identity line. So all of them were suggesting an association, a positive association between having IBD compared to not having IBD and developing ASCVD events. In this case, it's ischemic heart disease, the event of interest evaluated. And even though many of those studies were underpowered, they were small, or the follow-up was pretty short, or at least too short for a pretty young population, like typically is patients with IBD, you can see how point estimates are consistent, and the combined estimate of those meta-analysis is pretty clear association 1.24 with a very narrow confidence interval, and also on the right for the stratified analysis. So the observational cohort studies seem to be pretty consistent. What about, let me just take this person. Okay, so in terms of cross-sectional studies, also there seems to be a pretty strong association, particularly in the larger studies and in those with least limitations, even though obviously cross-sectional studies have important inherent limitations in terms of the temporal relationship and so on. But for example, this one, which is pretty recent and involved a collaborator of us from Ohio, from the university hospitals, you can see in this pretty impressive study in which they combine data from 26 nationwide healthcare systems. We're talking about 29 million patients, including almost 300,000 patients with IBD. And you can see how, and the gray line here in the graph is the one that is showing the odds ratio for each of the age groups. You can see how the association between having IBD and having a history of MI, this is cross-sectional stuff again, you can see how the association is pretty strong. And this is multivariable adjusted, particularly in the younger groups. And this is very important because consistently studies seem to suggest that the association is stronger in younger populations. And definitely this study points in this direction. Other cross-sectional studies have not shown this kind of signal, but definitely it's relevant to point to some of the limitations of those studies, like the study populations used and other considerations. But I think in general, the epidemiological evidence available is pretty compelling, showing this association between IBD and ASCVD. Nuances to be kept in mind from an epidemiological standpoint is the fact that risk seems to be particularly higher in terms of risk of ASCVD events during the active flares of disease. Also seems to be particularly higher during the first year of disease, which is typically a period of active disease or close to active disease. And also associations seem to be also present with other outcomes, like not only ASCVD events, but also venous thromboembolic events and arterial events, for example, in the mesenteric artery. In terms of other nuances to be kept in mind, definitely there seems to not be an association between IBD and CVD mortality. And this comes from meta-analysis as well. And this could be easily explained by the fact that we're talking about a young population with low death rates in general. And also the fact that this association is weaker, the association between IBD and ASCVD, than for other chronic inflammatory conditions like psoriasis and others. And this might be explained as well by the fact that IBD has long periods of relapse, during which the activation of the inflammatory cascade is almost normal, is not increased, and this can last for months or even for years. So this could be a potentially relevant explanation. All these nuances are consistent still with the potential association between IBD and ASCVD. So what about the mechanisms underlying? So Dr. Mehta has gone through them, and this is not the purpose of this talk. I would like to refer you to the recent paper that we published in JAC, even though many of these mechanisms have been widely described in other inflammatory conditions, and they are still being evaluated in patients with IBD. So even though there are signals and suggestions of many of these mechanisms happening and explaining that increased risk of ASCVD, definitely more mechanistic research is needed in this area. So what about those complexities in terms of the management? What happens when a preventive cardiologist is called to give an assessment of the risk management of these patients with IBD? So there are important complexities that we need to keep in mind. The first of all is the fact that there's a limited awareness on this association between IBD and ACVD. This is important for physicians who, when they are managing this kind of patients, they might not be aware of this increased risk, so they might not pursue an aggressive management of risk factors, or as much as it should be to make sure that the risk is decreased as much as possible, or the screening of the risk factors, also important for patients to know, and so on. Another important complexity is the fact that most often these patients are very young. So many times when they are diagnosed, they are less than 40 years of age. And as you know, tools for risk assessment, for ASCVD risk assessment, like the pool cohort equations, they're supposed to be used starting at age 40. So for example, for a 32 or 37-year-old patient, we're not going to have a tool that is going to tell us what is the 10-year risk of this patient in terms of developing ASCVD events. And this is important, particularly in terms of allocating preventive statin therapy in these individuals. But even if they are older, usually they are going to be between ages 40 and 50 at the time of diagnosis. And in those patients, we know that pool cohort equations, which are strongly driven by age, they are usually going to give low risk estimations in these individuals, even in the presence of multiple risk factors. And I will show you an example later. So even if we are able to stratify risk in these individuals, we're going to have limited opportunities, or it's going to be very unlikely that these individuals are going to be considered other thing than low risk at 10 years. So these are things to keep in mind, because we have limited tools to assess risk in these individuals. And as I mentioned before, we also have limited knowledge about the pathways that lead to atherosclerosis and ASCVD events in these individuals. We're still learning a lot about these. And this is going to be very important to identifying opportunities to reduce risk in this specific patient population. If we check the guidelines, and this is a table from our paper, summary table with the recommendations from both ACC/AHA and also the ESC European guidelines. If we go to the guidelines, you're going to see that there are several recommendations for patients with chronic inflammatory conditions, but some nuances and complexities need to also to be pointed to. So first of all, the guidelines don't specifically mention IBD, but at least they mention a list of chronic inflammatory conditions, and the list is presented with this such as expression. So I'm hoping that at this point we can all agree on the idea that IBD would be included in this list of chronic inflammatory conditions that the guidelines are referring to. But being honest, or being absolutely transparent in this process, IBD is not mentioned anywhere in any of these two guideline documents. Also, in terms of these complexities, important to keep in mind that even though the guidelines, they recommend using or considering chronic inflammatory conditions as risk-enhancing factors, and you know that risk-enhancing factors are features that are supposed to be used in individuals with borderline or intermediate risk at 10 years, and they are supposed to be used to make a stronger case to use preventive statin therapy to prevent ASCVD. The important thing to be keeping in mind is that most of our patients are not going to qualify for this risk enhancer thing, because they are going to be considered low estimated risk, not borderline, and definitely not intermediate, because most of them are going to be very young, and the pool cohort equations are going to lead to this usual low risk estimations in these individuals. So we're not going to be able to, so to say, take advantage of this approach in most of our IBD patients, unfortunately. Here's an example. If we, for example, check what the pool cohort equations tell us about this woman who is 41 years old, she's a female, she's a white female, she has high blood pressure, she has a total cholesterol of 220, she has low HDL for a female patient, and she has pretty high LDL. She's also a smoker, and despite having all these features plus IBD, she gets a low estimated risk with the pool cohort equations. So this is a perfect example of what happens with many of our patients, many of whom they are a bit older, but they don't have, for example, they are not smokers, so they are going to get even lower estimated risks. So in this patient, we are not going to be able to use the risk-enhancing approach. Other recommendations included in the guidelines, for example, they focus on the use of statins and the follow-up in terms of cholesterol management in patients using statins when they have chronic inflammatory conditions. But again, as I mentioned, most of them, they are not going to qualify for statin therapy in the first place because they are not diabetic, they don't have severe hypercholesterolemia, and they have low estimated risk. So again, these recommendations are not going to apply to many of our patients. Finally, the guidelines are very clear about the fact that we don't have evidence of whether the pool cohort equations are actually accurate in patients with IBD. And even though the key concern that has been raised with the pool cohort equations is risk overestimation in middle-aged and older patients, in younger patients, actually, the issue is the opposite. They tend to underestimate risk and underdetect individuals who are actually pretty high risk compared to people of the same age. And this is definitely going to be an issue in individuals with chronic inflammatory conditions because the full cohort equations, they only account for a few set of demographic characteristics and traditional risk factors, and they are not able to account for additional risk factors and mechanisms that are involved in these individuals. So we really don't know whether we are doing a good job or not with the full cohort equations when we assess risk in these individuals. Also, the guidelines acknowledge the fact that we don't know how to interpret the CAC score, particularly when it's a CAC score of 0 in these individuals. And they recommend, as in other populations, to continue to use preventive statin therapy and other therapies if CAC is 0 in individuals with chronic inflammatory conditions. And I might agree that in this patient population, which is young, and usually we get low risk estimations, I think the purpose and the priority would be to identify additional candidates for preventive interventions and not fewer with a CAC score of 0, which is maybe more relevant in older individuals and other populations. But definitely these are nuances and complexities that we need to keep in mind. And there are also complexities with the 2019 ESC guidelines related to chronic inflammatory conditions, which also recommend using these features as risk modifiers, which is something similar to the risk enhancing approach. I'm not going to get into more details because we're running out of time, but definitely something that we can also discuss. So after mentioning all these complexities and limitations, what can we do about this? So what should we do when we have a patient with IBD in our clinic in terms of managing the risk, the ASCVD risk of this population? So in our recent review, we came up with a group of two groups of approaches, to try to optimize as much as possible risk reduction in these individuals. On the one hand, we have the well-established approaches that we already have strong evidence, and we are very used to using them in our patients for ASCVD risk reduction. And then we have also pathways forward that I will discuss later. In terms of well-established approaches, the first thing would be definitely to make sure that the management of IBD is optimized, and definitely knowing that optimizing that management might have, and we need more evidence, of course, but that might have positive effects in terms of reducing the risk of ASCVD events should be an important factor to be kept in mind for, obviously, the treating physician, but especially for patients, because patients should know that adhering to the medications, adhering to the lifestyle changes, and to the approaches used to treat their IBD condition would be potentially something that will also benefit them in terms of reducing the risk of events. Again, we need stronger evidence of this, but I think this is a piece of information that is important to share with patients so that we further strengthen their willingness to adhere to the recommended approaches to manage IBD. And also the team approach. We're in the era of collaboration, cross-sectional collaborations between groups. This morning we had a fantastic talk about cardio-obstetrics. We're also talking a lot about cardio-oncology and even preventive cardio-oncology with collaborations between oncologists and preventive cardiologists. We think we also need to make sure that there's a good collaboration and a good communication between IBD and ASCVD prevention professionals to make sure that the assessment of ASCVD risk happens early in the process and that we maximize the opportunities that we have to reduce risk in these individuals. In terms of screening risk factors and managing those risk factors when present, even though this might sound common sense, if you check the literature, you'll see that patients with IBD actually get suboptimal preventive cardiology care, which is even worse than in the general population. So this is definitely concerning and an area for improvement in which maybe this team approach that I just mentioned could help us. Definitely screening for risk factors that we know that are definitely present in these patients. And we recently published a paper, I think it's in press, in which we show associations between IBD and several risk factors. This is widely published in the literature as well. And we can also show, we can also make sure that we try to find additional risk factors that might be not so well known in these patients, related, for example, to cholesterol efflux and other potential mechanisms that might be very relevant in these patients. So again, more data is needed, more evidence is needed in terms of what are the mechanisms that are involved in the ASCVD increased risk in these patients, but definitely involving the preventive cardiologist could help try to identify those and treat them once identified. And third, of course, we want to make sure that the guidelines that we have right now available are implemented, that people are aware of the risk-enhancing approach, that people are aware of opportunities to improve the management of lipids during follow-up in these patients when statins are started. And actually, if you check the same patient that I just mentioned before, same age and same burden of risk factors, but if instead of being a woman, this was a male patient, then the estimated risk in this patient would be 6.3%. This is now borderline risk. In this patient, it might make a lot of sense actually to start not only approaches to cessate tobacco use and also to reduce blood pressure, but also maybe a preventive statin would make a big difference in terms of the lifetime risk of this patient developing an ASCVD event. Finally, the pathways forward, and I think this is going to be great ground for discussion, but we mentioned a few. We mentioned the need for trials to show whether IBD modifying therapies can improve the risk or reduce the risk of ASCVD over time. We need to understand better the mechanisms involved. We also need to develop ASCVD risk estimators specifically for these individuals, maybe not 10-year, but 20 or 30-year lifetime prediction, and also risk thresholds to be used to allocate preventive therapies in these individuals. And also we need to learn more about the potential role of cardiac imaging. Should we be using CAC in these individuals, even if low estimated risk? Maybe not in all IBD patients, but maybe in those with more active flares, more frequent flares, longer duration of disease. This is definitely something for which we need further evidence. And maybe the role even of CCTA, showing, as Dr. Mehta just mentioned, not only calcified plaque, but all plaque burden. Well, these are definitely interesting, very exciting pathways forward that we need to further explore. Thank you so much, and I hope I didn't speak too fast. And back to you, Dr. Nasir. Thank you so much.
Dr. Cainzos, thanks for this very comprehensive review on that. So, Dr. Mehta, we got your slides, and I think so this is a great segue, considering that in these inflammatory conditions tend to affect more of the younger individuals, and I truly believe the role of atherosclerosis imaging, and more importantly, molecular imaging, to trying to understand the translational windows into the chronic inflammation. So I'm going back onto the slides, and you can guide me where to start with. And of course, there is a great deal of interest from our audience in trying to understand the role of PET as well as CTA in trying to understand the role of inflammation. So let's go on to the slides.
That sounds great. Thank you so much, Dr. Nasir. I appreciate that. So we can get back to you tell me where the slide, yeah, that's great. If you want to advance through advance. So I asked the question, advance, and right here, this is important, and I will spend about 5 more minutes going through our CTA approach. This slide shows that when one looks at the opacified coronary, you can subtract out the lumen volume and get the plaque volume. We all know that atherosclerosis is a disease of the lumen after it's been a disease of the wall. So here we're finding wall abnormalities early, and we have derived the plaque index where you take the plaque volumes and you normalize to the length of the segment. Next slide. And so what you're going to find here, and you can advance one more and just get the red box on, that the psoriasis patient here, the first 105 through the door, got a CTA, and it showed that their total plaque was higher than age and gender match controls. Their non-calcified burden was higher by 15%. And when one looked at the power of that association, you could look at that as sort of about an e to the x or e to the 0.13. It's about a 16% increase in non-calcified burden with the psoriatic state. Next slide. We all know on the call or on the seminar and others that non-calcified plaque is what leads to myocardial infarction. Next slide. So this is where I think it gets interesting. Next, you can click through. This is the first patient. He was a 38-year-old psoriatic. So I really loved Miguel's talk, and I loved Bincy's talk, because it showed us that the pathophysiology and the age dichotomy really needs to be thought through. 38, psoriatic, and comes in with this RCA infarct. And you just have to understand that that RCA infarct was in a CTA place where we had a year before CTA. And what we were able to show was that he had a high-risk plaque present in that artery. Next slide. And when one looks at the data from the table, click through and you'll see the red boxes, that psoriatic patients, next slide, have a 36% or 34% risk of having a high-risk plaque. Click one more time. Look at the age difference, 14 years. So compared to someone who's 14 years older, who has hyperlipidemia, a statin population, this patient with psoriasis has higher risk plaque. Okay, next slide. So the question is, what if you treated them? So next slide. And you're going to find that when you take a natural experiment of people who go on biologics versus not, this is not like Dr. Abraham's population. You need to treat IBD. You need to treat RA. You need to treat SLE. Those are deforming and destructive diseases. Whereas psoriasis, there are patients who will walk away with severe disease and say, I don't want treatment. Click the slide. You're going to find that the only thing that changed after 1 year of biologic therapy was that there was a reduction in inflammation, but none of the other risk factors changed. Next slide. So what did we find? There are 3 slides here that I'm going to go through fairly rapidly for the sake of time. First, lipid deposition in this actually decreased. So from panel A to panel B, you'll see that the necrotic core, which is in red, has reduced. Much to our surprise, and I'm sure Dr. Nasir is going to have a comment on this, is from on the bottom panel, one will find from panel A to B an increase in calcification. So anti-inflammatory therapy has aided in calcification of a high-risk plaque in 1 year. Next slide. Biologic therapy in this study, also you'll see the stars of what was used. Anti-TNF therapy, anti-IL-12/23 therapy, so ustekinumab, or anti-IL-17 therapy, and click through the slide if you don't mind. One will find that you saw in those who went on biologic therapy a 6% reduction in total plaque and non-calcified plaque, click the slide, compared to those who did not get therapy with biologics and let their psoriasis stay untreated. Next slide. And finally, when one looked at the high-risk plaque features, one will find, click through both times, Khurram, if you don't mind, you'll see that there is a reduction in fibrofatty burden and necrotic core in those who went on biologics versus those who did not, had an advancement of about 30% in those over time. Very dangerous to have unopposed inflammation. Next slide. Finally, what if you took this and you looked at diffuse coronary inflammation? This slide shows that our patients with psoriasis start with a lot of coronary inflammation, shown in the red on the left. And after 1 year of, in this case, anti-TNF therapy, there is less coronary inflammation at 1 year follow-up. Next slide. When one looks at the lipid-rich necrotic core, you'll see here, using a new software technique, that large round yellow space is actually a lipid-rich necrotic core that after 1 year reduces by about 33%. Next slide. Again, I promised that we would click through. So Khurram, you can just continue clicking and I'll just keep talking. Inflammation here drives this plaque. Biologic therapy stops it. And if you've enjoyed what we've liked here, this is the time to pull the article, this article, Application of Molecular Imaging in Research of Chronic Inflammation. Next slide. This is going to give you, imagine this patient, instead of having psoriatic plaque on his left wrist and his ankles, he had IBD. And I think that all these processes, whether it was Dr. Abraham bringing up the gut and all of the pro-inflammatory cytokines, or Miguel bringing up himself all of these possible prothrombotic factors, this needs to be understood. So click to the next slide. I do provide my Twitter handle here. Please do follow me, but better yet, please email me if you have things that I've talked about too quickly. Thank you for going back to the slides. I feel complete now. I really do.
It was fantastic. Thank you so much. So now we will start with some discussion. So Nehal, I'll start with you. So you mentioned the chronic inflammatory conditions. You highlighted your work in psoriasis. Of course, there's tons of data regarding CVD risk in rheumatoid arthritis. You are working with SLE now. Of course, the IBD is the new kid on the block here as far as we are concerning this cardiovascular disease axis. The question is, are all these chronic inflammatory conditions the same, or are there some distinct features among these conditions that may predispose them to a higher risk or a lower risk?
You know, the discussion is the discussion of types of inflammation, and I don't think we have an idea of that yet. What we know is that psoriasis was thought to be a T-cell driven disease. We've now redefined it as both a neutrophilic and a T-cell mediated disease. Lupus was once thought to be a rheumatologic disease driven by B cells and lymphoid tissue, now thought to be driven by neutrophils as well. So I don't think we know. One truth that I remind everyone is inflammation within the body is dangerous to remote sites of the body. So if you do check a CRP in a patient with IBD and it's 5, you know that they have IL-6 mediated inflammation in the body. You know, based on other models, that that's bad. but I don't know if we can liken it, which is why I'm so excited to see the IBD field explode, if you will, with these types of studies, because we would have never thought that a skin disease, what that used to be called just a skin disease, is now one of the leading research models for chronic inflammation in humans, right? And I think that IBD provides us yet another way of thinking about pathophysiology and age dichotomy for atherosclerosis.
Just carrying this conversation forward, a question for Dr. Abraham. Now, IBD, do you think that may be slightly different considering the alteration in the gut microbiome, which is really one of the major, I would say, causal factor for the severity of these conditions in IBD, considering now maybe some shared role in CVD risk? What's your thoughts in this regard?
Right, so the microbiome is actually quite fascinating. We know there's dysbiosis in inflammatory bowel disease, but of course the gut's right there. This is the biggest organ that is exposed to the microbiome on a day-to-day, minute by second to second basis, right? However, we're seeing now the microbiome research and studies explode, that the microbiome is involved with not just gut health, but also cardiovascular health that we're talking about, neurological health, even Alzheimer's has been linked. So definitely there is a role, but the other thing we haven't reached in our microbiome evaluation research is that there's so much to learn, right? So we know there's dysbiosis, but we also know that there's a significant amount of interplay that takes place with our immune cells in that gut layer and what's going on in the microbiome. So there's this interplay and signaling that takes place right at the gut level that goes back to our bloodstream, not just through the gut, but to the bloodstream. And our bloodstream is going to all the organs of our body. So obviously, whatever that interplay is, that signaling that takes place, that contributes to pro-inflammation rather than homeostasis, is contributing to all this disease.
Thank you so much. Carrying on, a question for Dr. Cainzos. Dr. Mehta did point out the value of finding a signal, and I'll also ask Nehal to comment on that, why it's important to find a signal in young individuals that they may be at risk. And so far, what your group has found, Dr. Cainzos, any thoughts on the early signal of MI in the young individuals with IBD?
Absolutely. I think definitely the key challenges that we have in preventive cardiology right now, as we have mentioned before, on the one hand, we have older individuals in which we don't want to be using medications and interventions that are aggressive without a strong evidence that they are going to benefit from them. And we are using tools like Axiro to try to identify people who actually are at high risk, and not only as a consequence of the age, but other factors. I think in the young, we need to identify strong markers of increased risk that can help us identify populations, small populations in which we could maybe do further, like for example, use further risk assessment, further tools, screening or aggressive screening of risk factors and so on. And I think definitely the IBD population is a good candidate for this. We're talking about more than 3 million people in the US. This is a pretty highly prevalent disease in the young. And the same way, we are also researching ethnic groups at increased risk, like South Asian populations. We're also focusing on women with obstetric conditions that are associated with increased risk of CVD. I think focusing on the IBD population to further try to identify those individuals that could be at increased risk of events is going to definitely make a big difference in terms of public health, because again, we're talking about a large population in which we've identified the right approaches to stratify risk and treat accordingly. I think we could definitely prevent a number of premature events and reduce the chronic burden of disease in the US, definitely.
Now, just shifting gears towards more from maybe stable disease to people who are presenting with flares. A question from the audience would be, both for Dr. Abraham and Dr. Mehta, would psoriasis patients as well as IBD who are presenting with either more frequent or more longer flare-ups, do you think they may have maybe at a much higher risk of ACVD or atherosclerotic disease?
Right, so fantastic question. I think one of the challenges that we have in inflammatory bowel disease is that patients' symptoms don't always correlate with their endoscopic findings. So this is very important, right? So when patients complain to us about abdominal pain, diarrhea, diarrhea, rectal bleeding, we're there, right? We know we're going to take care of them. We know there's inflammation. However, there's a significant number of patients out there who don't have a lot of symptoms, or they have been so used to their disease that they downplay their symptoms, they don't complain too much. So those patients, I believe, are the highest risk because they go unrecognized, either undiagnosed or undertreated for a long period of time, where they have this underlying burden of inflammation that's ongoing. And so this flare really could last from a few days to months to, in fact, actually years for those patients. And can you imagine having chronic inflammation from a cellular level for years can lead to so much damage in the body?
So Nehal, on this line, I know that your group has led a lot of work on the inflammation, vascular inflammation using PET FDG. Do you think that can give us some more insights? Does everyone who has a flare, psoriatic flare, has an increased inflammation, or are there certain conditions or patients within the psoriasis who may get that?
No, so if you are flaring on the skin, you will be flaring within your vasculature. Our FDG studies have shown that when you do flare, you have an immune activation that starts in the skin and it seeps its way through the body. I think that what I have to say is very interesting. During her talk, Dr. Abraham actually brought up that we have to be very aware that when these patients are flaring, that they have their risk of thrombosis and coagulation disturbance. And I think that is a very astute thing to say, because with our psoriatics, we've had 11 events in my cohort. We have 400 patients we've been following. The event rate's a little bit lower than I would have expected. But in those patients, when you have your event, whether it's ACS or whether it's stroke, we've had a few cardiovascular deaths, the patients were having a flare of their psoriatic disease 9 out of 10 times. So 90% of the time, the body is in this dyshomeostasis. And what's probably happening is people have either activated myeloid cells, so they're thrombogenic and they're clotting. They may have disrupted endotheliolitis, if you will, a diffuse vascular inflammation. And I think that I would be remiss not to think about how COVID has helped shine light on this, that when you take somebody with a massive insult of inflammation, there are people who have various responses to that, which are probably programmed genetically. And if you look at one having a chronic inflammatory disease, they're at a heightened immune activated state anyway. So when they're in their flares, they really have a lot of cellular disturbance. So I think that we need to A, prevent flares, and then B, remind our patients that disease activity is not okay.
This is great. So we have seen significant alterations with flare-ups in their aortic vascular inflammation. We have seen changes, early changes in high-risk plaque. And of course, we have seen that utilization, at least in a non-randomized fashion, of significant reduction in some of those features. The question, just asking Nehal, and of course I'd like Miguel to give some comments on that, is do you think at some point we may move from clinical endpoints to maybe these imaging endpoints for applications of some of these biologic therapies, not only to treat these underlying conditions, but maybe get approved for cardiovascular risk reduction?
I'll start and then I'll pass it over to Miguel. I'll take the easier one. It's going to take a large randomized trial to get a 1A, and to get that 1A, I think is going to take large groups with events. Now, could the FDA or an approving body actually take a surrogate? Well, we know the Zetia story. It did work. It got an approval based on an ultrasound rather than an event. We also know how that turned out. I think that we need to remember that the Evaporate story, as well as the recent, different agents of fatty acid metabolism, have shown that there's promise. So what we might be able to say is, rather than them getting approval or indication, we may find more and more support with randomized trials. I do think that we are onto something with treating primary disease state and seeing off-target benefit. Miguel, what do you think?
Oh, I completely agree. Thank you so much. I think this is a great question. I think in young populations, definitely having a large trial with hard outcomes is going to be financially challenging, because we're talking about populations in which, as Dr. Mehta just mentioned, we are seeing increasingly lower rates of events in these populations, even if they are enriched with risk factors and so on. So it's going to be challenging to have a sufficiently powered, feasible study with hard endpoints. But obviously, that will be the strongest type of evidence. If not, I think definitely plaque burden is going to be a very powerful surrogate. And I think we might be moving in that direction in younger individuals, in which we want to see whether certain interventions are reducing the burden of plaque, as Dr. Mehta showed in his studies in patients with psoriasis. I think maybe past examples from other types of interventions in other patient populations, which focus on maybe management or improvement in the management of one specific traditional risk factor, or maybe LDL levels, etc. This was an approach that maybe had important limitations, but I think if we focus on reducing plaque burden, which is a really, really strong risk factor for incident events, I think this is going to be a pathway that is going to allow to come up with very powerful studies. Maybe not for a class 1A recommendation, but maybe, as Dr. Mehta mentioned, an increasing body of support for this kind of intervention. So definitely I think this is going to be the most feasible approach for research moving forward in young individuals.
Thanks, Miguel. And 2 more questions. One is, of course, Dr. Abraham, once you've mentioned that treatment of IBD is personalizing treatment. And of course, the question here is, are all biologics created equally? For example, we have seen significant evidence with anti-TNF alpha, now emerging therapies like IL-12/23 inhibitors. There seem to be some mixed signals. The original meta-analysis in 2011 published showed more cardiac adverse events, especially in the utilization in the early stages. Large national insurance studies from France demonstrated significant higher risk with those therapies cardiovascularly. However, recently also from Mayo Clinic, we got the signals that they had similar benefits as far as cardiovascular risk reduction in the IBD population, both with the TNF alpha as well as IL-12/23 inhibitor. Your thoughts? And same question to Nehal. Do you think that all biologics are similar as far as anti-inflammatory from a cardiovascular risk perspective?
So I'll start with GI. So we have very few head-to-head trials in inflammatory bowel disease biologic medications. The only one we have currently is vedolizumab against adalimumab, a anti-integrin compared to an anti-TNF. But I did want to mention that they're not all created equal, and because inflammatory bowel disease, such as all immune conditions, are so heterogeneous, right? It's not one size fits all. So there are some patients who respond quite well to TNF alpha reduction, while others do quite well with anti-integrin therapy, and others do well with all of them. And we haven't got to that point of personalizing treatment to exactly which medicine is going to fit the best for that person that walks into our clinic with the new diagnosis of a chronic condition. That's where we need to get to. Now, there have been studies looking at potential for reduced cardiovascular disease risk with the biologic therapy versus increased. And I must say, overall, I think we're all in agreement that inflammation contributes to increased cardiovascular risk. We're seeing that over and over again. With these medical therapies that reduce the risk, actually these medical therapies that reduce inflammation, we really should be seeing a reduction in the risk of cardiovascular disease. Now that's one study that I want to point out because I think it's been mislabeled in a sense of the French study that showed ustekinumab potentially could increase the risk of cardiovascular disease, but they had over 9,000 patients. So that's fantastic, large numbers. However, I think this is very important, especially when we're doing journal club for our trainees and all of that, to really look at what that study is looking at, right? So this had 9,000 patients. Majority were psoriasis. There was, I think, like 4% was like Crohn's or so. And what they found was there was an increased risk of ustekinumab, initiating ustekinumab in patients that already had increased cardiovascular risk factors or had coronary artery disease to begin with. Well, no brainer, like if you already have increased or a prior history of coronary disease, you're going to have that increased risk regardless, right? Now, if you did not have coronary disease, adding ustekinumab or initiation did not increase that coronary disease risk. So, okay, so that's great. But what they also, it's interesting that study, the majority were psoriasis patients. So for a psoriasis patient, start on ustekinumab, which is a fantastic medication to treat psoriasis. These patients had to have significant, moderate, or at least severe disease. So severe disease itself can contribute to inflammation, therefore contribute to coronary disease. So there's a little bias in this population. I think the study should have been done in not just looking at ustekinumab, but looking at other biologic therapies, right? So look at anti-TNFs and initiating that in a psoriatic patient with already known coronary artery disease. Does that also increase the risk with the other medication, or is it just that having that underlying coronary disease and having underlying active inflammation that prompts you to start a biologic therapy is what triggers the coronary artery disease or acute, disease?
So much more complex than what we know, right? It seems, Nehal, you have been looking underneath the bonnet, looking at the arteries and plaque and inflammation. Have you seen any differential impact as far as some of those issues are concerned?
So it's a good question. We do get that asked from the reviewers on all of our smaller studies. So remember, our studies range from between 120 to 200 people followed for 1 to 4 years. So we're not talking huge numbers here, but we are always asked to do 3 types of analysis. Subgroup analysis, we're asked to do head-to-head analyses, which we are not powered for. And we're also asked to do, analyses which follow patients over time for progression, which we're clearly not powered for. So first, all of the agents work to improve coronary vascular health, all of them, over time, meaning that you will not progress your vascular plaque. You will always either stay the same or regress. That is about 99.5% true. We have had 1 or 2 patients who have had a transient spike over 1 year and then they've gotten better. The differences between agents. So if I started getting a little bit more technical about the vascular components, a lipid-rich necrotic core tends to be a neutrophil-mediated event. It's necrotic. It has a strong impact of almost caseous necrosis when you look at other organs. And so when you think of acute inflammation, you can't help but think of neutrophilic activity. There's a tremendous signal and crosstalk between helper T17 cells and neutrophils. So when I think of lipid-rich necrotic core and I look at our study, in fact, the largest reduction in lipid-rich necrotic core happened to be in the IL-17 group. But both Stelara, ustekinumab, IL-12/23, and anti-TNF did reduce the lipid-rich necrotic core. It happened to be the 17 was a little bit stronger. If you look at coronary inflammation by PFI, in fact, anti-TNFs had the strongest reduction of about a 12% reduction of PFI for diffuse coronary inflammation over a year. Biologically, that might make sense. You're having PFI, which is peripheral fat attenuation, measuring water exchange for inflammation. And so radiographically, it makes sense that if the TNF signal is changing, there's less bioactive TNF to make that attenuation. Therefore, you get a rise in your attenuation and less inflammation. And then finally, I did show you that there's a change in total plaque and non-calcified plaque burden. And in that study, lo and behold, anti-IL-17s as well as anti-IL-12/23s had the largest reduction in total plaque and non-calcified plaque burden, with a 12 to 13% reduction in both of those groups. So the bigger question that we're trying to answer now is, if that's the outcome, what are the proximal steps along the lipid, inflammatory, and metabolic pathway that may differ? And that's where you start seeing cool stuff. And I'd love to hear Dr. Abraham chime in about this. But in anti-TNF therapy and psoriasis, there's something where we get as an ApoB shift. They make more LDL, they make more triglycerides, they gain weight. They gain about 5 to 6% of their visceral adiposity. And so therefore, the acute, if you will, 1 year effect of an anti-TNF may actually not be vasculoprotective. However, our group and others have shown that 8 years and onwards of anti-TNF therapy is associated with a reduction in MI. So clearly, the lipid pathway for TNFs show you that there's atherogenicity, but the systemic inflammation may prevail. And I wonder if other disease states see this anti-TNF signal. But a long-winded way of saying the three classes of biologics in our disease state all tend to improve vascular health, but they have different effects on the intermediaries in between, lipid, inflammatory, and metabolic.
Actually quite fascinating, because we also see the same, where we have patients that have active inflammation and we start them on biologic therapy and they do better, right? However, in the GI tract, when there's inflammation, multiple things are going on. So it's hard for us as GIs to say, okay, well, you start on biologic therapy, now you're gaining weight. Well, multiple factors are going on here, right? So first, there's active inflammation. So we know with inflammatory status that there's increased metabolic rate because of all the stuff that's going on with our immune system. And that's just increasing our metabolism. But once that inflammation is reduced, the metabolism gets back to more of a normal. The other thing is, when the gut is inflamed, it's not able to absorb the nutrition as it needs to, right? So I have patients who eat all day and all night, and they still can't gain weight. In fact, they're losing weight because they're just going to the bathroom, having diarrhea multiple times a day, or having rectal bleeding, and they can't maintain that nutrition. So once you start them on biologic therapy, they finally start healing the bowel, and now they're able to actually absorb the nutrition that they weren't able to before. So now you have a twofold effect of them gaining weight. Now the third component is that TNF alpha does play a role in lipid physiology, right? There is some lipogenesis that may be going on here as well. So then there's that additional component of it that contributes potentially to weight gain. In fact, we've actually found this so fascinating that we are in starting up, we started looking into this before the whole COVID situation happened, where we notice an increased risk of fatty liver disease in our patients that have inflammatory bowel disease. And we see this especially after they get started on therapies and they start feeling better. And it's this rapid fatty liver progression, and they don't have the typical risk factors that we would think for a metabolic syndrome, right? They don't have the diabetes, they don't have the hypertension, but all they have underlying is their inflammatory bowel disease. So very fascinating metabolic component of this.
Wow, this has been totally fascinating. Now, it's at least from a cardiologist's perspective, a preventive cardiologist's perspective, and even from, I would say, for my colleagues in internal medicine and primary care, it's now becoming pretty clear that chronic inflammatory conditions is likely associated with a very high CVD risk. Now, to end, just from your perspective, Dr. Abraham, Dr. Mehta, especially from your experience from GI and psoriasis, and Dr. Cainzos from a preventive cardiologist perspective, now, who are these patients that should be tested or screened for early CVD risk assessment? What type of assessments would you recommend? And once you've identified, how do you plan to treat them? So feel free to give your final verdict.
So I think from the inflammatory bowel disease patient perspective, we know the standard risk factors from medicine, right? So older patients, family history, and also known factors like hyperlipidemia, hypertension, diabetes, etc. But the other group of patients I think we start as GIs, we need to start looking into would be the younger patients that had chronic inflammation that's been ongoing for quite some time, maybe those that have been undertreated for some time, maybe those patients that have had major fluctuations in their weight because of their disease and treatment, etc., where there's lots of metabolic changes that's going on pretty rapidly as well. And those patients would be the ones that we need to be assessing more regularly than we had done in the past.
Nehal?
I think that we are at a point where we need to remember untreated inflammation is bad. We need to remember that when you have someone in front of you, there are 3 simple things that you can tell them about untreated inflammation in order to mitigate their risk of CVD. And I have them remember the 3 Bs. Number 1, get their body mass index checked. So they should know their body mass index. We have a tremendous rampant association between chronic inflammation and obesity and the situations that happen with obesity. Number 2, check your blood pressure. We call psoriasis the visible killer, but hypertension since the 60s has been the silent killer. In our work, we're showing that hypertension, in fact, is one of the most potent risk factors for development of NCP. The third B, get your blood checked for cholesterol and glucose. We've gotten good enough where we don't even need them fasting anymore. Random samples will tell us your risk for diabetes and risk for heart disease over time. So untreated inflammation is bad. We need to educate our patients on their own 3Bs. And finally, we have a lot to learn about what to do about getting this word out there. I think that we have made tremendous progress. We have to thank Paul Richter, Peter Libby, and others in the field who have really pushed this forward, but we're only 10%, maybe 12% of the way there. So I hope that we can all, come together as providers and continue that message.
Miguel, final thoughts.
Couldn't agree more. I think definitely we need to identify those patients in which further risk assessment would be justified. And I think Dr. Abraham mentioned several key features of patients with IBD in which it might make sense to go further. More flares, longer duration of disease. And I'm going to be a bit provocative here. There are several recent guidelines like the National Lipid Association, the SCCT guidelines, and also this is mentioned in the ACC guidelines, considering the possibility of considering CAC scoring in individuals who are low estimated risk, but they have a premature family history, ACVD. The same way, this is something that we are starting to accept. That's a young population in which it might make sense to go further and test for subclinical plaque. I think the next frontier could be patients with chronic inflammatory conditions like IBD, psoriasis, and so on. Potentially with CAC, and maybe in the future with further reductions in radiation dose, further reductions in the need for contrast, further reductions in cost. Maybe this could be a patient population in which maybe CCTA could give us a lot of information in terms of risk management early in the process so that we can curtail many premature events that are happening in these individuals. So I will leave this here, food for thought, and I think a lot of research in the next year is going to inform this potential indication maybe in the future.
Well, thank you so much, everyone. This has been a fascinating discussion. Truly, it's becoming clear. Inflammation, like other major risk factors, it's something that needs to be taken seriously. Our primary care colleagues needs to understand that these are high-risk patients. We are at the cusp of trying to understand the next phase of treatments that may not only reduce and manage this disease, but also as we identify these patients for those treatments, cardiovascular risk, not only assessment, but hopefully management, as discussed by the panel, is critical. I'm truly inspired and I think so excited about the opportunities in pushing the frontier, and I believe that the imaging, especially the plaque imaging and the inflammation imaging, molecular imaging, all of this are going to have great opportunities in understanding not only cardiovascular disease overall in these individuals, but also in trying to decipher the initiation of atherosclerosis and the early pathogenesis of disease. Lots of more work to be done, but again, this was a great start, and I hope that this will lead to much more collaborations among folks multidisciplinary in multiple areas, in inflammation, in GI, in epidemiology, population science, and imaging, getting all of us together to find all these answers. Thank you so much again joining for this. Hopefully we'll see you, all of you, next month with our next series. Thank you.
Thank you.
Thank you very much. Bye.